Hi, my name is Dr. Lauren Tholke. I'll be presenting on if there's a role for the use of paralytic agents to ease closed reduction during operative treatment of type 3 supracondylar humerus fractures in children. I'd like to thank my colleagues, Dr. John Schlechter, Bryn Gornick, Trenton Lum, and Dr. Jessica Van Michael. Myself or my co-authors have nothing to disclose. All data set has been collected from Children's Hospital of Orange County, and I'm also from Riverside University Health System Orthopedic Surgery Program. A little background information: supracondylar humerus fractures are the most common pediatric fractures found in children less than 7 years of age. It is estimated that 96 to 98% of supracondylar humerus fractures are of the extension type, and 26% of those are Gartland type 3 variant. The image on the right demonstrates a Gartland type 3 variant where there's no intact posterior hinge. The standard for treatment of type 3 supracondylar humerus fractures is attempted closed reduction with percutaneous pinning. At our institute, paralytic agents are at times utilized during the treatment of supracondylar humerus fractures to determine by the anesthesiologist as an inductive agent or at the request of the treating surgeon with the intent that a neuromuscular blockade may ease the closed reduction maneuver. Our purpose of the study was to investigate the effect of intraoperative paralytic administration in regards to anesthesia time, surgical duration, fluoroscopic time, radiation exposure, and conversion from closed to open treatment when treating supracondylar humerus fractures in children. Our study is a retrospective IRB-approved case series of 319 extension type 3 supracondylar humerus fractures treated operatively from 2016 to 2019. Our inclusion criteria was they must be a type 3 variant, treated surgically with attempted closed reduction with percutaneous pinning, must be between 1 and 10 years of age, adequate follow-up to monitor changes in radiographic union. Exclusion criteria were that anyone over the ages of 10 due to the increased complexity of pediatric supracondylar humerus fractures after the age of 10. Flexion type patterns, Gartland type 1 and 2 were excluded. No availability of anesthesia type or missing fluoroscopic information, and loss of follow-up until radiographic union. 5 patients were excluded from our study who received both rocuronium and succinylcholine, and 1 patient was excluded who received vecuronium as a neuromuscular blockade due to the underpowered sample size. We established 3 categorical groups. The first group being children that underwent surgical treatment of the supracondylar humerus fracture without a paralytic agent. We had 240 in that group. We had a second group that were treated with rocuronium as a paralytic agent with 43 patients, and a third group that underwent treatment with succinylcholine as a paralytic group with 36 in that group. We measured sex, age, body mass index, laterality, anesthesia duration, surgery duration, injury to operating time, emergency room to operating time, the orthopedic surgeon, orthopedic resident surgeon, postgraduate year, conversion to open treatment, fluoroscopic time, fluoroscopic radiation exposure, post-procedure Baumann angle, and post-procedure lateral hemorrhocapitellar angle were recorded. All radiographic measurements were performed by 1 orthopedic surgeon to reduce inter-observer variability. We found that there was no statistical difference between the groups with regard to surgical time, time to the operating room, time from the emergency room to the operating room, gender, BMI, injured laterality, number of preoperative and postoperative complications, or postoperative radiographic measurements. We found the average age for the extension type 3 Gartland supracondylar humerus fractures at our institute to be 5.2 years with a standard deviation of 2.2 years. The rocuronium group did have a statistically higher age group of 6.4 plus or minus 2.2 standard deviation years with a p-value of less than 0.001 when compared to the no paralytic or succinylcholine group. We also found that both radiation exposure and radiation time in seconds to be statistically higher in the rocuronium group when compared to the succinylcholine and no paralytic groups with a p-value of less than 0.001. The rocuronium group also had a longer anesthesia duration with a p-value of 0.003. The use of paralytic agent to facilitate closed reduction of a type 3 supracondylar humerus fracture did not correlate with shorter surgical times or improved outcomes. Anesthesia duration, surgical duration, fluoroscopic time, and radiation exposure did not appear to be positively affected by the use of a paralytic agent. The use of a paralytic agent as an adjunct to facilitate closed reduction was not supported by the findings of our study and therefore cannot be recommended for routine use. The use of paralytic agent during the treatment of supracondylar humerus fracture should be left at the discretion of the anesthesiologist if necessary for the anesthesia induction maintenance. These are our references. Thank you.